If you take amlodipine or metoprolol and feel more tired than you did before, which medication is the more likely cause? For many adults over 60, the answer is metoprolol, but that answer is not as simple as saying one medicine is good and the other is bad. Amlodipine and metoprolol lower blood pressure in very different ways. One mainly relaxes your arteries, the other directly reduces how strongly and how quickly your heart responds. That difference can determine whether you feel normal, slightly sluggish, dizzy when standing, or completely drained after an ordinary walk. In this video, you will learn why metoprolol is more likely to cause fatigue, how amlodipine can create a different kind of tiredness, what your pulse may reveal, and which warning signs require prompt medical attention. Most importantly, you will learn how to discuss fatigue with your doctor without abruptly stopping a medication that may be protecting your heart, because stopping metoprolol suddenly can be dangerous. And assuming that every episode of fatigue is just old age can be dangerous too. A quick note before we begin. Senior Insight Guide provides general education, not personal medical advice. Nothing in this video is a diagnosis or prescription. Never stop, switch, reduce, or change the timing of amlodipine, metoprolol, or any other medication without speaking with your doctor or pharmacist. Before we continue, tell me your age and which medication you currently take, amlodipine, metoprolol, or both. Consider an illustrative example. Imagine a 69-year-old man named Robert. Robert has taken amlodipine for several years. His blood pressure is reasonably controlled, although his ankles occasionally swell in the evening. After developing a fast, irregular heartbeat, his clinician adds metoprolol. Within 2 weeks, Robert notices a change. He can still get out of bed. He can still complete his daily activities, but everything seems to require more effort. His morning walk feels longer. He becomes tired while climbing stairs. When he carries groceries from the car, his legs feel as though someone quietly removed 20% of their power. Robert assumes this is part of aging, but when he checks his pulse after sitting for several minutes, it is 52 beats per minute. Before metoprolol, it was usually in the 70s. His blood pressure is also lower than usual. Robert does not stop the medication. Instead, he records his pulse, blood pressure, fatigue pattern, and the activities that have become difficult. He takes those observations to his clinician. That is the safe response, because the medicine may be contributing to the fatigue, but the correct solution depends on why Robert was prescribed metoprolol in the first place. It may have been prescribed to control an abnormal heart rhythm. It may be treating angina. It may be part of evidence-based heart failure therapy, or it may be helping protect his heart after a heart attack. Metoprolol is used for hypertension, angina, heart failure, and post-heart attack care, and it may also be prescribed for certain irregular heart rhythms. It slows the heart rate as part of its intended action. The goal is therefore not to blame the medication. The goal is to determine whether the treatment is appropriately balanced for the individual taking it. Think of your cardiovascular system as a home water system. Your arteries are the pipes. Your heart is the pump. Amlodipine mainly works on the pipes. Metoprolol mainly works on the pump. That is the governing difference. How amlodipine works. Amlodipine belongs to a group known as dihydropyridine, calcium channel blockers. That name sounds complicated, but the central idea is straightforward. Amlodipine reduces calcium entry into the smooth muscle cells surrounding your arteries. Those muscles relax, the arteries widen, and blood can move through them against less resistance. Your heart does not need to generate as much pressure to push blood forward. With long-term use, amlodipine generally does not produce a major change in heart rate or the heart's electrical conduction. How metoprolol works. Metoprolol is a beta-1 selective blocker. It reduces the effect of adrenaline-like signals on the heart. As a result, the heart usually beats more slowly and with less force. This reduces blood pressure and lowers the heart's oxygen demand. That can be extremely useful when the heart is beating too quickly, working too hard, experiencing angina, or recovering from certain cardiovascular problems. But it also explains the fatigue. When you stand, walk quickly, climb a hill, carry a bag, or become emotionally stressed, your body normally raises your heart rate to deliver more oxygenated blood to your muscles. Metoprolol intentionally limits part of that response. For some people, this produces no noticeable problem. For others, the heart cannot accelerate enough to match the activity they are attempting. The person experiences that mismatch as fatigue. The medication is not sedating the muscles directly, it is lowering the cardiovascular response available to support those muscles. That is why metoprolol related fatigue often becomes most obvious during activity. Based on the medication's mechanisms and official adverse reaction information, metoprolol is generally the more likely of the two to produce prominent fatigue. The prescribing information for extended release metoprolol identifies tiredness among its most common adverse reactions, alongside dizziness, shortness of breath, slow heart rate, and other effects. Some labeling based on immediate release, metoprolol experience reports tiredness and dizziness in approximately 10 out of 100 patients. Amlodipine can also cause fatigue. In placebo-controlled trials included in its official label, fatigue was reported by 4.5% of patients receiving amlodipine and 2.8% receiving placebo. Its most characteristic dose-related adverse effect, however, was ankle or leg swelling. Those figures cannot be treated as a direct head-to-head competition. The drugs were studied in different trials with different populations, doses, medical conditions, and methods for recording side effects. The metoprolol label itself warns that adverse reaction rates from one drug's trials cannot be directly compared with those from another drug's trials. Still, the overall clinical pattern is clear. Metoprolol is more likely to cause fatigue by slowing the heart and limiting exercise response. Amlodipine is more likely to cause swelling, dizziness, or heavy legs, which can then be experienced as fatigue. Now let us separate those patterns more carefully. Metoprolol-related fatigue often appears during activity. You may feel reasonably comfortable while sitting, then you begin walking. Your legs feel heavy, your pace slows. An activity that used to take 10 minutes now requires 15. You may notice that your heart does not seem to beat much faster, even when the work becomes harder. This is sometimes described as reduced exercise tolerance. Imagine driving a car with a device that prevents the engine from moving beyond a certain speed. On a flat road, everything seems normal, but when the road rises, the car cannot generate its usual extra power. Beta blockers can create a similar experience. Metoprolol blocks part of the adrenaline signal that normally tells the heart to accelerate. That does not automatically mean the dose is wrong. For someone with angina or a rapid heart rhythm, controlling that acceleration may be exactly the desired therapeutic effect. But when the slowing is excessive for that individual, fatigue can become prominent. The extended release metoprolol label specifically warns about bradycardia, an abnormally slow heart rate, and recommends monitoring the pulse. It also notes that the risk may be higher in people with certain electrical conduction conditions or those taking other medicines that also slow the heart. Do not diagnose a problem from one pulse reading, but do pay attention to patterns. For several days record, your resting pulse after sitting quietly, your blood pressure, the time you take metoprolol. When the fatigue becomes strongest, whether exertion causes dizziness, breathlessness, chest discomfort, or near fainting, bring that record to your healthcare professional. Do not independently skip a dose to see whether you feel better. Suddenly interrupting metoprolol can worsen angina and has been associated with serious cardiac complications. Official guidance says chronic treatment should not be stopped without medical supervision. Amlodipine-related tiredness may feel different. Instead of a clear inability to raise the heart rate, the person may notice swollen ankles, tight shoes, sock marks, or lower legs that feel increasingly heavy as the day continues. Amlodipine widens small arteries more strongly than it changes the veins that carry blood back toward the heart. This can increase pressure in the tiny vessels of the lower legs, allowing fluid to move into the surrounding tissue. The result is peripheral edema, In the amlodipine clinical trial data, edema increased with dose. It was reported in 1.8% of participants taking 2.5 milligrams, 3% taking 5 milligrams, and 10.8% taking 10 milligrams, compared with 0.6% taking placebo. The person may describe the consequence as fatigue. My legs are tired. I do not want to walk. My shoes feel tight. I lose energy in the afternoon. But the mechanism may not be classic whole body fatigue. It may be swelling, discomfort, and reduced willingness to move. That distinction matters because ankle swelling has more than one possible cause. It may be related to amlodipine, but it can also occur with heart failure, venous disease, kidney problems, liver disease, a blood clot, or prolonged sitting. Do not assume that new swelling is harmless simply because amlodipine is known to cause it. Contact your clinician when swelling is new, persistent, severe, rapidly worsening, or accompanied by breathlessness, chest symptoms, sudden weight gain, one-sided leg pain, or redness. And do not try to treat amlodipine swelling by changing the dose or adding a water pill on your own. A clinician needs to determine the cause first. Either medication can cause fatigue when blood pressure becomes too low for the person taking it. This risk becomes particularly relevant when several pressure-lowering medications are combined. Imagine that you are taking amlodipine to relax your arteries. You are also taking metoprolol to slow your heart. Perhaps you additionally take a diuretic, an ACE inhibitor, an ARB, a nitrate, a prostate medication, or another medicine that can influence blood pressure. Each prescription may be reasonable, but their combined effect may occasionally produce lightheadedness, weakness, or unusual tiredness. The symptom frequently becomes worse when standing. You rise from bed or a chair. Blood temporarily moves toward the lower body. Your cardiovascular system must respond quickly to maintain adequate circulation to the brain. If the response is delayed or overly suppressed, you may feel lightheaded, unsteady, weak, foggy, as though the room has dimmed, or as though you must sit down immediately. Amlodipine's label acknowledges that symptomatic low blood pressure is possible, although its gradual onset makes sudden, severe hypotension less common under ordinary use. Metoprolol labeling lists hypotension and bradycardia among important adverse reactions and warnings. After 60, these symptoms are especially important because dizziness and weakness can increase fall risk. Do not chase a single low reading by changing your medication. Instead, use correct technique. Sit quietly for approximately 5 minutes. Support your back. Keep both feet on the floor. Place the cuff on a bare upper arm. Keep the arm supported near heart level. Take 2 readings about 1 minute apart. When your clinician has advised you to check standing pressure, follow the exact instructions they provide. Record the readings alongside your symptoms. The combination of numbers and symptoms is more useful than either one alone. Timing provides an important clue. Medication-related fatigue becomes more plausible when the symptom begins soon after starting metoprolol, increasing the dose, changing from one formulation to another, adding a second heart rate lowering medication, developing liver impairment that changes drug exposure, or beginning a medicine that raises metoprolol levels. Extended release, metoprolol labeling notes that certain CYP2D6 inhibiting medications can increase metoprolol concentrations. It also advises lower initial dosing and gradual increases in people with impaired liver function because metoprolol is metabolized by the liver. Common CYP2D6 inhibitors include certain antidepressants and other prescription drugs. That does not mean those medicines should be stopped. It means your pharmacist should review the full combination. A medication list is not merely paperwork. It is one of the most important diagnostic tools you can bring to an appointment. Include prescriptions, over-the-counter medicines, sleep aids, allergy products, pain relievers, vitamins and supplements. Sometimes the issue is not one medication. It is the interaction between several. Amlodipine is not automatically free of age-related considerations. The body clears it slowly, and its terminal half-life is approximately 30 to 50 hours. Official prescribing information reports that older adults have reduced clearance of amlodipine, producing approximately 40 to 60% greater total drug exposure. This is one reason the cautious dose selection and a lower starting dose may be appropriate for some older patients. This does not mean everyone over 60 should take the lowest dose. It means dose decisions should account for blood pressure response, swelling, dizziness, liver function, body size and frailty, other medications. And the reason amlodipine was prescribed, a person may tolerate 5 milligrams for years, but develop symptoms after moving to 10 milligrams. Another may tolerate 10 milligrams without difficulty. The dose written on the bottle does not tell the whole story. The person's response completes the prescription. For people with diabetes, there is another reason to investigate unusual fatigue carefully. Low blood sugar can cause weakness, confusion, sweating, shakiness, hunger, and exhaustion. A rapid heartbeat is one of the warning signs many people learn to recognize. Metoprolol may blunt that rapid heartbeat warning because it blocks beta signals to the heart. Official drug information also warns that metoprolol can increase the risk of low blood sugar in some circumstances and mask early warning signs, particularly when someone is fasting, vomiting, or unable to eat normally. Therefore, a person with diabetes who suddenly feels weak or unusually tired should not automatically assume the medication is merely making them sleepy. Check glucose according to your diabetes plan. Know the symptoms your clinician has instructed you to watch for. Seek urgent help for severe confusion, loss of consciousness, or a low glucose level that cannot be corrected using your prescribed plan. Do not skip metoprolol because it can mask one symptom. Work with the clinician managing both your heart condition and diabetes. Fatigue is a symptom. It is not a diagnosis. A medicine may contribute, but other causes can exist at the same time. These include anemia, thyroid disease, sleep apnea, poor sleep, dehydration, depression, infection, low blood sugar, vitamin deficiencies, kidney or liver disease, an abnormal heart rhythm, worsening heart failure, or simply taking several medications with overlapping effects. Persistent fatigue should therefore be evaluated rather than dismissed as either aging or a side effect. Many diseases, medications, and lifestyle factors can produce similar symptoms. The pattern can provide clues more suggestive of metoprolol-related fatigue. The fatigue began after starting or increasing metoprolol. Your resting pulse is substantially lower than your previous baseline. Activity has become noticeably harder. Your heart rate does not rise much during exertion. You experience dizziness or weakness when standing. You feel cold in your hands or feet, more suggestive of amlodipine-related fatigue. Your ankles or lower legs have become swollen. Shoes or socks feel tighter later in the day. Your legs feel heavy rather than your whole body feeling sedated. Symptoms became worse after an amlodipine dose increase. You experience flushing, dizziness or palpitations, more suggestive of another condition. Fatigue appears with black or bloody stool. You have unexplained weight loss. You snore heavily and stop breathing during sleep. You awaken with headaches. You are short of breath while lying flat. You have fever or signs of infection. Your skin appears unusually pale. Your fatigue is severe despite a normal pulse and normal blood pressure. These are not diagnostic rules. They are observations to bring to a healthcare professional. Neither medication is universally better. They have different jobs. Amlodipine may be selected because it lowers blood pressure effectively by relaxing arteries and generally does not intentionally slow the heart rate. Metoprolol may be selected when heart rate control is part of the treatment goal or when the patient has conditions such as angina, certain arrhythmias, heart failure, or a history of heart attack. For someone with uncomplicated high blood pressure and troublesome fatigue, the treatment discussion may differ from that of someone with heart failure or atrial fibrillation. That is why you should not ask only which medicine has fewer side effects. I ask, why was this particular medication prescribed for me? What benefit is it providing beyond lowering my blood pressure? Is my pulse within the range you intended? Could the dose, timing, formulation, or another medication be contributing to my fatigue? Should another cause of fatigue be investigated? Those questions protect both comfort and cardiovascular safety. People often assume that moving a tiring medication to bedtime will solve the problem. Sometimes clinicians do adjust timing, but timing is not a harmless experiment. Metoprolol exists in immediate release and extended release forms. They are not used identically. The regular tablet may be taken once or twice daily, while extended release forms are generally taken once daily. Metoprolol should be taken consistently and exactly as directed. Amlodipine lasts for a long time and maintains its blood pressure effect across the day. Moving it from morning to evening may not eliminate swelling or fatigue because the medicine remains active for many hours. The safest response is not, I will move this pill tonight. It is, could the timing of this medication be adjusted safely for my symptoms and treatment goal? That small change in wording matters. It turns self treatment into informed care. Most medication related fatigue is not an emergency, but fatigue becomes more concerning when it appears with cardiovascular or neurological symptoms. Seek urgent medical evaluation when tiredness or weakness is accompanied by chest pressure, squeezing, or pain, severe shortness of breath, fainting, new confusion, one sided weakness, difficulties speaking, a very slow pulse with dizziness or near fainting, a rapid or irregular heartbeat with chest symptoms, blue lips, severe wheezing, sudden major swelling, or an inability to remain awake. Metoprolol related bradycardia can include sinus pauses and heart block in susceptible patients. The label instructs clinicians to monitor heart rate and address severe bradycardia medically. Call emergency services rather than driving yourself when symptoms suggest a heart attack, stroke, severe breathing problem, or loss of consciousness. Do not wait to see whether the next dose makes the symptoms disappear. Before your next appointment, create a simple 7-day record. Do not change the medication. Observe the pattern. Each morning, record the time you woke, how well you slept, your resting blood pressure, your resting pulse, the time you took each medication during the day, record when fatigue began, what you were doing when it appeared, whether activity made it worse, whether you felt dizzy after standing, whether you experienced breathlessness or chest discomfort, whether your ankles became swollen. If you have diabetes, record glucose according to your established plan. In the evening, grade your fatigue from 0 to 10. 0 means normal energy, 10 means you could barely function. Also record whether the fatigue is sleepiness, muscle weakness, heavy legs, breathlessness, mental fog, or reduced stamina. These experiences are often grouped together under the word tired, but they point toward different possibilities. Bring the record, your medication bottles, and your complete medication list to the appointment. That gives your clinician something more useful than the statement, I have been feeling tired lately. It creates a pattern they can evaluate. You do not need to arrive with a proposed medication change. Arrive with precise questions. You might ask, is my resting pulse lower than you intended? Could metoprolol be limiting my activity tolerance? Could amlodipine related swelling be making my legs feel tired? Is my blood pressure dropping too low when I stand? Does another medication increase the effect of metoprolol or amlodipine? Do I still need this medication for the same reason it was originally prescribed? Should I be evaluated for anemia, thyroid disease, sleep apnea, or another cause of fatigue? Would a different dose, formulation, or treatment strategy be medically appropriate? The clinician may decide that no change is needed. They may order blood tests. They may examine your heart rhythm. They may review home readings. They may modify a dose gradually, or they may conclude that the medication is not causing the fatigue at all. The correct outcome is not necessarily a different pill. It is a better explanation. So, which medication causes more fatigue after 60? Metoprolol is generally more likely to produce significant fatigue. Its intended effects include slowing the heart rate and reducing the heart's response to adrenaline. In some people, that creates low energy, diminished exercise tolerance, dizziness, or weakness. Amlodipine can also cause fatigue, but its more recognizable pattern often includes ankle swelling, heavy legs, flushing, or dizziness. Remember the distinction. Metoprolol may make the pump respond more slowly. Amlodipine may make the pipes wider but allow fluid to collect in the legs. Either medicine can contribute to symptoms if blood pressure becomes too low, and either medicine may be innocent when fatigue is actually being caused by another medical condition. The 5 points to remember are: metoprolol is the more likely fatigue-producing medication overall. A slow pulse makes metoprolol-related fatigue more plausible, but one reading is not a diagnosis. Swollen, heavy legs make amlodipine a stronger suspect. The reason the medication was prescribed is more important than the side effect list alone, and neither medication should be stopped or changed without professional guidance. Metoprolol can be especially dangerous to stop abruptly. Track your symptoms, know your pulse, measure your blood pressure correctly, bring the pattern to your clinician. You should not have to choose between protecting your heart and functioning through the day without first finding out whether the treatment can be better balanced. If this helped you, type fatigue in the comments and share this video with someone over 60 who takes a blood pressure or heart medication and believes constant exhaustion is simply part of getting older. Subscribe to Senior Insight Guide for calm, research-based explanations of what common medications are actually doing inside your body. In the next video, we will examine the 7 warning signs that amlodipine, metoprolol, or another blood pressure medicine may be lowering your pressure more than your body can comfortably tolerate. Take good care of yourself. You are worth the effort.